Okay, welcome everyone, and thank you for being here. My name is Brooks Roach. I am Manager of Patient Knowledge and Connection with Diabetes Canada. And I'd like to begin by acknowledging that I am joining this webinar from the traditional and unceded territory of the Mi'kmaq people. And wherever you're joining or watching from today, I invite you to just take a moment to express some gratitude and recognition for the Indigenous lands that we now call Canada. We are here today to talk about a pair of topics that often do not receive enough attention in the diabetes community, or certainly traditionally haven't. So lo and behold, people living with diabetes do have sex and do use drugs. And we wanted to come together to share some knowledge and tools to keep in mind when navigating these pieces of our personal lives. So I'm very, very pleased to welcome our two guests today, Dr. Alice Cheng, who is an endocrinologist at Trillium Health Partners and Unity Health Toronto, and an associate professor at the University of Toronto. Welcome, Dr. Cheng.
Thank you. Thanks for having me. It's a great topic.
It is, yeah, and happy to have a couple experts. And our other expert is Dr. Celine Huot, who is a full clinical professor, pediatric endocrinologist, and head of the endocrinology division at CHU Saint-Justin in Montreal, as well as president-elect of the Canadian Society of Endocrinology and Metabolism. It's a full bio, and welcome, Celine. Happy to have you.
Hello, everyone. For the purpose of our talk, I won't be talking about children, but adolescents and adults.
Okay, excellent. So again, thank you both for being here. And I personally, as someone who lives with type 1, am just really interested to hear about some of these topics that have been taboo, and to dive right in. So the format today is that our two experts will be answering some key questions that they've heard from patients and seen in their work and research. I'd also like to take a moment to remind viewers that while this session is relevant to people of almost any age, the recommendations you'll hear are intended for an adult audience. So as Celine mentioned, adolescents or their caregivers are strongly encouraged to ask further questions specifically to their diabetes care team. We will be taking questions from viewers, so you can ask your questions by replying in the comments below. And if you would prefer to keep your questions anonymous, recognizing this may be a sensitive topic or one you would rather keep private, you can send a direct message to Diabetes Canada on Facebook. So with that, we will dive right into the discussion, and I would like to pass it to Dr. Cheng and ask, let's start at the beginning. So if someone living with diabetes was considering starting to have sex, either for the first time or with a new partner, what are some of the key considerations they should keep in mind?
So I think a very important message to take away from today is to remind everyone that someone living with diabetes can absolutely have a satisfying and enjoyable sex life, just like anyone else who may not live with diabetes. So I think that's a very important starting point to come from. And just like everyone else, in order to try to achieve that satisfying and enjoyable sex life, it is very much about communication. It's about strong, direct communication with your potential partner so that everybody is on the same page. And specific to diabetes, there are some practical considerations that one needs to discuss with their potential partner. So let's start off with how can sex impact one's blood sugars, or vice versa. So remember, sexual activity is exercise. So it is considered a physical activity, it is considered exercise, and therefore the potential for a low blood sugar is certainly there, depending on how vigorous the sex may be or the duration, etc. But all of that does in fact is exercise, and therefore could make the blood sugars lower. So ensure that your partner is aware of that possibility. Ensure that you have candies or Dex tabs or juice or somewhere within arm's reach. Then that, of course, is important to consider. The other thing that one needs to think about is potential wearable technology that you may be using. So for some of you who are listening, you may be wearing a sensor, you may be wearing an insulin pump. There may be a tubed pump, a tubeless pump. So there are certain technologies that you may be wearing on your body. And I think it's important to have a conversation with your partner about that piece. And this is always one of the fun debates that one could have at a session is, are you a pump on or pump off kind of person? Some people choose to leave their pump on when engaging in sexual activity, and some people choose to take their pump off. And I think that's very much a personal decision, and it may change from session to session. But it is important that, again, you've thought about it and that you've discussed it with your partner, because it's just sort of, what happens if my leg gets tangled in the tubing, and, those kind of things do need to be discussed ahead of time, and sort of go with the flow, and so everybody's not anxious or surprised or unsure about what to do in those situations. So I think those are kind of important conversations to have with a potential partner. And those are some of the ones that are sort of specific to diabetes. And one other thing that I will mention about blood sugars, I said how sexual activity can impact the blood sugars, but the blood sugars can impact sexual activity. So if someone is in fact experiencing hypoglycemia during sex, then that is going to impact performance. So I think that is also relevant to be aware of, is how blood sugars can also impact sexual activity.
Thank you, Dr. Cheng. All very useful things to think about. And it's the debate of pump on, pump off does rage on. Wondering if you could speak a little bit about sexual function and diabetes.
Sure. Excellent question. So those living with diabetes, particularly of longer duration, may in fact experience sexual dysfunction or abnormal function from a sexual perspective. Now, let's start with in men. So in men, I think we've all seen the commercials. It's no longer a taboo topic, which is great. Men may experience erectile dysfunction. Now, as we know from the TV commercials, et cetera, it's not just men living with diabetes who can experience erectile dysfunction, but in fact, any man can experience erectile dysfunction. And particularly those with diabetes, though, they may have some more risk factors for it, such as some circulation issues or neuropathy, nerve-related issues from longstanding diabetes that may impact erectile function. So I think the key there is, again, to communicate, but to communicate with your healthcare team. Because if you are experiencing any erectile dysfunction, please mention it. And what your team will do is perhaps do some blood work to check for things like low testosterone, which again, any man may experience, but those living with diabetes may experience it a little more often. And then that can be treated. And as well, of course, we've got excellent medications to address the erectile dysfunction, which can be very effective. But if it's not discussed, then of course your healthcare team is not able to help you. Now, it is our role to ask the question, but sometimes the question does not come up, in which case we would very much hope that our patients would be able to share the information with us. And then being able to maintain glucose levels close to target is ultimately going to help with that situation, and sometimes can be an additional motivating factor for people to work on their blood sugars. So that's on the male side of things. Now let's talk about female. Now, female sexual dysfunction is definitely not discussed publicly. You don't see TV ads about it. It's not discussed in movies and TV shows, etc. And it's also not something that we're very good about asking. However, we should be, and we do realize that female sexual dysfunction is common in general, but also in those living with diabetes. And it may come in the form of impacting either desire or impacting arousal or impacting orgasm, which are sort of phases of the sexual response. And depending on where the issue is, there may be different treatments that could be offered. So again, number one is to mention it. Is to discuss it with your healthcare team. And then based on what the situation is, there may be blood tests that need to be done to rule out other contributing causes. There may be simple therapies like vaginal creams that could deal with vaginal dryness, or it may involve a referral to a sex therapist who could help with some of the sexual desire pieces. But it can happen, and it's not something to sort of just brush under the rug. It is something to discuss with your team, because there may very well be things that could be done to help you.
Yeah, thank you, Alison. I think that point of communication is really resounding, like across all of what you shared. And I'm wondering, just thinking about if someone, as you say, it's great if they do get this targeted question from a healthcare provider, specifically asking about this. And I was just thinking, I wonder if you have any advice for folks who may not have that question coming in from a healthcare provider. How could they feel comfortable about reaching this topic?
Well, one thing that I think all of us do, even if we forget to ask the pointed question, all of us will do it towards the end of the visit would say, do you have any other questions, right? I would hope that all of us tend to end our appointments with that. And then that is a great opportunity to actually say, this is what I have experienced over the last, whatever period of time. One thing I would say is that all of us as healthcare providers want to know if you're having an issue. We may forget to ask, but we appreciate when you share that information. Is everyone going to know how to help you? Maybe not. But is everyone going to want to know and then direct you to someone who may be able to help you? The answer is yes. So people are going to be open to it. People are going to appreciate the fact that you've shared it. However, we sometimes forget to ask, and that is very much our issue. I think in men, we tend to remember, but I got to say, when I went through medical school and residency, asking women about sexual function just was not, we weren't taught to do it. So therefore, we don't ask. But please bring it up, because we want to help. And like I said, even if the person you're mentioning it to doesn't know what to do, they can send you to someone who can help.
I think that's really helpful, keeping in mind that it's not a deliberate blocking out of the topic. It's just people are busy. People are healthcare providers may just have a lot on their plate and not explicitly ask, but that they want to help is a really important lens to keep in mind. Okay, we're going to press pause on topic 1 of sex and move on to drugs. So with that abrupt shift, I'm going to ask you, Dr. Huot, if I am an individual who lives with diabetes and uses drugs, which is many of us, whether that's alcohol, cannabis, or illicit substances, what do I need to know?
That's a great question as well. If we take the different substances differently, alcohol and cannabis are now legal in Canada. Cannabis has been now legalized in Canada since 2018. So people are more willing to give information legally and report their use of cannabis. So what we've known since it's been legalized, it's that, for instance, if in most of the provinces reported use is between 15 to 25%, according to the different provinces, people living with diabetes will report officially less use than what's commonly reported for other people not living with diabetes. And the people living with type 1 diabetes report it more often. Of course, the type of use, the type of product, the mode of administration differs. So that's not necessarily asked once people contribute the information. What has stemmed out are potential risks, though. So the risks that people should be aware of. And then again, we don't know what the chicken and the egg is. Is it just an association? Is it really related to diabetes? Is it related to other factors? We have to keep that in mind. But for type 1 diabetes, the use of cannabis has been related to a slight deterioration in the glucose control, namely the HbA1c. The famous blood test that everybody gets once they see their physician. And but that again, when you analyze more according to a level of education, socioeconomic level, this may not be as much of an impact and a risk. What has been mostly reported in people living with type 1 diabetes is an increased risk, let's say 2 to 3 times, of having diabetic ketoacidosis, and that's a severe complication of type 1 diabetes. So what is more so, what's also reported is the fact that if you have a tendency to have diabetic ketoacidosis, which will bring you to the hospital, you have more of a risk of being readmitted within the next year if you have use of cannabis, and more so if you use cannabis and other substances. So these are risks that people living with type 1 should be aware of. As for type 2, the use is less reported, but numbers seem to indicate that there is an increased risk of having vascular problems, of having cardiovascular problems as well. And these things have to be taken into account. There are also there's also information coming in that maybe the function of the kidneys may be compromised at some point. So these are potential risks. Then again, there's up till now, we don't know, is it a matter of long-term use? Is it a matter of amounts that are being used? Is it a matter of the mode of administration of the cannabis? Is it the type of cannabis? We don't know. So this, at least for cannabis, is known. And the use of cannabis not only may impact on glycemic control and also on potential complications of diabetes, but it's also being written also that it may impact on the way we self-care for our diabetes. So for instance, the way we eat can be perturbed while using cannabis. The way we check our blood glucose and the level of vigilance may be perturbed as well. So for those reasons, there may be risks associated with the glycemic control and also the way we self-care for ourselves if we live with diabetes. So that's for cannabis. I will go along with what Dr. Cheng has said before. If you don't engage in the discussion with your patients, I deal with adolescents as well and young adults. As Nora Roberts, the famous novelist, said, if you don't ask a question, the answer will always be no. So ask the question, engage in it. If you don't feel comfortable, well, at least you'll know the information. And as Dr. Cheng said, please bring it to the people who would at least give some advice. But officially, the recommendations overall from physicians would be to try to minimally use cannabis recreationally. I'm not talking here about medicinal use of cannabis. This is a different topic completely. But if it is going to be a part of your, I would say, extracurricular activities, then the best thing to do is to make sure that somebody will help you to ensure that at least your self-care is not perturbed because of your recreational use of cannabis. These are the main lines. For other substances, there isn't much published, both for type 1 and type 2 diabetes, more so in Canada, because it's illegal. So if you report it, you're not supposed to use it. So we doubt very much that the numbers are reliable there. As for alcohol, alcohol for anybody should be a topic of discussion in any follow-up in healthcare situation, that's for sure. And alcohol, more so when its use is not considered moderate, can have impact on health. There are additional risks for people living with diabetes. And then again, it's hard to generalize the information because yes, there's the type of diabetes that can influence your reaction to the alcohol intake, more so if it's more than moderate or just socially once in a while. But there's individual predispositions as to how you metabolize the alcohol and whatever. So the recommendations are general, they are for safety, but it's a matter of controlling the risks. Risks can also, with the use of alcohol, include worsening of other health problems, more so if you have them to start with. So for instance, high blood pressure, very common people living with type 2 diabetes, an increase in some of the fats in the blood, which are called triglycerides. So more so if you have them. Those people who already have inflammation to their pancreas can have serious bouts of inflammation, which are very painful and can lead to very serious medical imbalances as well. And also it's it's known that alcohol use can impact on the function of the liver. And as we know, the liver is very important, not only in releasing the sugar we need in between meals and when we sleep, but it's also very important to metabolize or to help the way some of our medications work when we treat diabetes. So for those reasons, there are moderate, I would say, risks in the moderate long term, but in the short term, the use of using alcohol, I would say within more than less than minimal amounts can impact in some individuals in the short term. And there are potential 2 risks. If your blood sugar is already very, very high, more so if you have type 2 diabetes and you take certain medications, your blood sugar is very high, and you take alcohol, this can lead to dehydration. Alcohol makes you go pee, and then again, your blood sugar may spike right up, and you may feel very dehydrated and end up very, very sick. While most people will agree that many types of drinks include carbohydrates, sugars, the initial thought would be, oh yeah, the alcohol would lead to an increase in blood sugar. Not necessarily wrong, but don't forget, not all alcohol types include a lot of carbohydrates, sugars. But what actually happens is once your body starts getting rid of the alcohol, then it's so busy that the liver can't provide sufficient sugar in between meals, or more so if you've drunk alcohol without having a meal or food in the meantime. So the risk of having alcohol, of taking alcohol, is actually to having a low blood sugar. Low blood sugar can also, more so in people with type 1 diabetes, but in type 2 diabetes, if you take even something with a lot of sugar in the drink, your pancreas is still secreting insulin. It can go really high up in terms of secreting insulin, and then you will end up having hypoglycemia anyway. So let's not forget there is sugar in alcohol, but the immediate danger is more the low blood sugars. And this can be a problem until you wake up the next morning, whether you have a headache for having drunk too much or not. But you can also have a very severe headache if you're in a hypoglycemia or have treated a hypoglycemia during the night. So there are some measures that we recommend. We discuss this openly with all our patients. Pretending that people will never drink alcohol for many will prove to be difficult. And so there are many ways in which you can prevent. For sure, there's the types of alcohol, i.e. concentration here, what is included in terms of sugars in the alcohol that you drink, monitoring, checking for your blood sugar, having a partner, somebody who helps you to actually make sure that the blood sugar is still normal. And these are additional, this is an additional help that you may need simply because alcohol may perturb your sense of feeling well or unwell. And let's not forget also that alcohol may lead to symptoms which may be difficult to distinguish from hypoglycemia, or, oh, I'm just having a little bit of a headache because I've drunk too much there. So overall, these are the messages for substance and alcohol use. Yes, engage with patients, but I would say also, let's discuss it openly. Prevention here is much better than having to deal. I speak for myself, dealing with adolescents. You have this 17-year-old in the emergency who doesn't feel well, and then they have to explain to their parents what actually happened. Whereas, you know, if they discuss it before beforehand, this would never have shown up on the radar.
Okay, thanks very much. That's a very in-depth rundown. Like, I feel like that's a great sort of starting kit if someone's looking into whether it's beginning to use alcohol or cannabis, or looking to revisit the way that they engage with those substances. That's a really helpful lay of the land. So thank you. On the note of opening that dialogue, and similar kind of point around the importance of just communication, and you can, I love that quote about the only way to get a definite no is not to ask. So just go first. On the note of an open dialogue, I would now like to open the floor to questions. So we have a couple that have already come in, and I would just encourage folks to engage, as mentioned, in the comments section or via direct message, and potentially treat this as a chance to test out the way that you might ask about your own health situation, because we want this to be, this is a very open, understanding setting. So I want to welcome any type of question. So a couple that have come in already, which I'll share with you folks. And the first is probably the most direct and easy to answer is Franklin asks, is there a link to studies on cannabis and diabetes? So what I'll say is certainly, and I can connect with you, Dr. Huot, and we can share those in the comments section on this video after the fact. So just stay tuned and we'll follow up. But great question, and happy to help you explore a bit further. The next question is regarding the use of CBD to help sleep issues. So wondering perhaps, Celine, if you could touch on the distinction between perhaps THC and CBD, if relevant, and then, as you had mentioned, that these sort of medicinal uses, if it's been prescribed.
The literature on THC, which is known to have effects on quotes unquote well-being, either stimulating or relaxing properties, are, I would say, more preponderant in the literature. The information is more preponderant than it is for CBD. The quality of the literature for CBD, because it has various uses, is more difficult to get. THC doesn't act on the body on the same receptors as CBD. THC acts throughout the body, and there are, this is why we can explain, this is how we explain actually why it has some central nervous system positive and sometimes not so positive effects. Whereas CBD acts elsewhere in the body, and it acts on, let's translate it this way, pain receptors. So those pain receptors have not been as well characterized as the receptors for THC. So the effect of CBD on sleep, more so in people with diabetes, whether it would have a positive impact, I'm not in a position to tell you how necessarily it would work, whether it would enhance or improve the situation. Don't take from this message that I don't believe in the medicinal use of CBD. All I'm saying is that we don't know as much yet, and we can't focus and target those specific people who could potentially benefit from it as of today.
Okay, very helpful. Thank you. The next comment we've received is in and around menopause. So I'll field this one to Alice, and it's this individual has lived with type 1 diabetes for 46 years and is having trouble with blood glucose levels since starting menopause. They say they've gone to the gym and sugar is going up, and since menopause, it's quote unquote never normal.
So menopause is a pain in the butt for everyone, diabetes or not, because it is a change in your hormonal profile. And what's happening is that your ovaries have packed up, they're quit, the eggs are done, and you no longer get the cycling of hormones, which in some ways is good, but then you're now missing estrogen, which can then wreak havoc on things like sleep, mood, energy levels, for some people, memory. And then when you're not sleeping, that then worsens the memory. And it can also wreak havoc on blood sugars, but in a different way. When you were having your periods, the havoc that the hormone was causing was this fluctuation. But if your periods were predictable, you could somewhat predict what was going to happen and adjust your insulin accordingly. With menopause, you lose that fluctuation, which is great, but then your body needs to readjust itself. And that perimenopausal period is very difficult because sometimes your hormones go up and then sometimes they go down, and then it's unpredictable. So then it makes it very hard to be able to adjust your insulin accordingly. For some women, their insulin requirements go down in menopause, but then for others, it goes up because there may be an associated weight gain that may occur in menopause. And then with increased weight, increased insulin resistance, and then therefore higher insulin requirements. So it's very hard to say, there's a rule of thumb that it's definitely going to go up or definitely going to go down. All that I can say is that it is all about frequent monitoring and then tweaking of your therapy accordingly. Your body's response to exercise should be no different really in menopause versus not in menopause. However, because your body has changed and likely body weight has changed, then it is different from before. And the perimenopause, like I said, is just a big old roller coaster. So I wish I had a simple answer for you. I wish I had a magic bullet for you, but it really is about frequent monitoring and then frequent adjustments. If you're not sleeping, if you're having terrible hot flashes, then please speak to your healthcare team because there are things that can be done to help. Hot flashes are very difficult because they feel like hypoglycemia, and sometimes it feels like hyperglycemia, and then you don't know what's going on. So again, it's about frequent monitoring. So I wish I had a magic bullet for you. If it is terrible, certainly hormone replacement therapy is something that can be offered safely in people living with diabetes as well. So if you're miserable, please go see your team because there are ways to try to lessen the symptoms of perimenopause and menopause.
Thank you. And I hope this is helpful to our audience, and thank you for asking, and hope that can steer you in the right direction, recognizing it's sometimes, as you say, tough to have the magic bullet, but sometimes just heading down the right street at least can be a good first step. Another question, and it's somewhat related, although at a very different potentially life stage, and it's about planning for pregnancy. So Alice, I'll field that back your way.
So first message, just like I had with sex, I think the first message is to say that women living with diabetes can absolutely have a healthy pregnancy, healthy, successful pregnancy. And that is the expectation in 2022, that would be the case. It does require some extra thinking, and that extra thinking is planning, which technically other pregnancies should have as well, right? So it is just about planning ahead and avoiding surprises. So specific to diabetes, there actually is a checklist that you can find on the Diabetes Canada website, which is sort of like a preconception checklist. So we want to make sure that certain things have been achieved prior to conception. So these include things like having the blood sugars at target, so an A1C less than 7%, preferably even less than 6.5, making sure if they're on any other medications that can impact pregnancy that we stop those. Things like statins, ACE inhibitors, just getting rid of those medications, ensuring that you've screened for complications. So having had your eyes checked within the past year, making sure your kidneys have been checked, the urine has been checked, and then folic acid. Ensuring you've been taking folic acid at least 1 milligram per day for a good 3 months prior to conception, so that your body's chock full of folic acid. And then that way the developing embryo will have the nutrients that it in fact requires. And those would be the components of the preconception checklist. So blood sugars, other medications, folic acid, eyes checked. screening for complications. So always plan your pregnancy, obviously with your partner, but plan it with your doctor and your diabetes team. And I often joke with my patients that as soon as you discover you're pregnant, the first phone call you make should probably be to me and then to your partner in that order, because it's critical that the team be aware, and that once you are pregnant, that we put you in the right kind of clinics where you're going to get very specialized care, and we're going to stay on top of things. Because in pregnancy, it's critical to then maintain the glucose control to ensure successful pregnancy, and as well maintaining vitamins through the first part of the pregnancy. Aspirin may be needed in the beginning part as well. So there are great things that we can do, and it's all about preparation, planning ahead, communication, and then once you are pregnant, let us know ASAP, and we put you in with the team. And the expectation is for successful pregnancy.
Okay, thank you. And also very helpful and prescriptive. You know, get your tests, get your folic acid. So, and call Alice first. Call your team first.
Yeah, call me first.
Okay. Another question, and this is in recognition. Celine, you had mentioned, you know, that it's much easier to report on and have a bit more of a direct answer on substances that are legal. And this person's wondering if you have any specific guidance, or, you know, just how to approach something if they are interested in trying or have been a user of illicit substances.
One very easy way of getting the information is, I'll take the example for adolescents. I don't ask an adolescent, have you used cannabis or pot or whatever, their terminology, in the past year. I usually ask them, how many times have you actually used pot in the last year? I usually get frank answers when I ask it that way, rather than do you use it generally? So this is one way. And if somebody, even if somebody answers, oh, just once or whatever, I'll probably take this opportunity as well when I ask about cannabis to ask about alcohol at the same time, and other substance use as well during those things. And I must say that the ease with which you bring up the question will probably help in the answer. So if you don't feel very comfortable with it, you may even rehearse if you have adolescents at home, or with your partner, or even rehearse at home, so that at least when you ask the question, you don't feel ill at ease yourself. So that's one thing. And usually when we address substance use, whether it be alcohol, cannabis, or something else, I usually try to approach it by substance. If it's a real problem in terms of use, then I would ask the help of my colleagues in adolescent medicine, because usually there are other issues at stakes than just the diabetes then. But when I deal with a particular use of a substance, first goal is to try to cut down if it's at all possible. And there are many ways, and we can also send you the link as to how you can screen for that, and also how you can help people to at least start cutting on the use, recreational use or non-recreational use, or abuse. Let's call things the way they should be called for some people. We would be pleased to send you those links.
Okay, great. We'll share those as well in the comments. So we'll have a little bundle of resources for viewers after the fact. And thanks for the question, because again, it can be difficult to ask when something is taboo, or in this case, you know, even illegal. It can be hard to own up to something and try to get help. So
if I may add also, one of my personal fears is that somebody will come up with a name I don't know, and I have no idea what the substance is about. Well, then I just ask, okay, tell me about it, and I'll read about it. Sometimes it's just a different name for something that already exists, or a mixture of things that already exist. But I'm very humble when it comes to that. I would say every 2 weeks I hear a new name I haven't heard, and well, that's part of education, I guess.
Yeah, we have a question that's not doesn't cleanly necessarily fit into the two categories we've discussed, but I think it may be relevant just to ask you folks, given your expertise. And it's a question: can you help me with pain, sciatica, and arthritis for diabetes, as I am taking too many meds and nothing is helping? Do you have any guidance for this person?
So I can, Celine, I'll jump in here. Pain management is difficult, obviously, as this person who's asking has already alluded to. And in the diabetes space, we often think about diabetic neuropathy or nerve damage that can manifest as painful diabetic neuropathy. And in the case of painful diabetic neuropathy, we sort of go through a cocktail of medications that we may choose to try, right? So we may choose to try things like tricyclic medications. We could then try things like pregabalin. We might try things like gabapentin, duloxetine, sort of in that antidepressant group that may help. And sometimes things like non-steroidal anti-inflammatories, NSAIDs, can be helpful. And then I personally do not tend to prescribe the narcotics or the opioids simply because I don't know enough about them, nor do I follow people closely enough to be able to prescribe that safely. But in those individuals where we sort of try those basic things and it's not cutting it, I always will involve a neurologist, because the neurologist can then do the proper test to see, is this actually painful diabetic neuropathy, or is this some other form of neuropathy? And then if necessary, they will also involve the pain clinic. So for the person who's asking the question, who clearly sounds frustrated, which is completely understandable, if you're not already engaged with a pain clinic, I would ask for that referral to a pain clinic. Because at the pain clinic, they see all types of pain, not just diabetic neuropathy pain, but all types of pain, and will have access to different modalities and treatments and blocks and things that certainly your endocrinologist would not have access to, and even most neurologists would not, or your primary care physician. So I would strongly recommend that you visit or ask for a referral to a pain clinic to have assessment there. And cannabis may very well be part of the armamentarium for treatment of the pain, but not something for you to experiment with on your own, because it is about the dosing and the type, and then the CBD versus the THC, and it gets fancy, but in a good way, and not something that you would just sort of buy at the store and then try out, right? So I would encourage, again, a referral to a pain clinic, who often will have expertise in cannabis as well as a potential pain treatment.
Okay, thank you. And just to add, noting that been tested to see if it is in fact neuropathy, it's a disc herniation. So again, maybe an added layer of complexity. We also have a question, and I'll just direct this person. It's Sonia is asking a question about the ODSP, specifically if FIASP will be covered in insulin pumps for those who are on ODSP. And I would just advise, I think we have some print resources, but I would advise reaching out to via email info@diabetes.ca or 1-800-BANTING, as they have all the most updated resources and can dive in a bit more depth with your specific situation to help you. So I just steer you that way. And thanks for asking. So I want to just say a big thank you to those who asked questions and expressed their curiosity, and thanks for some really thoughtful answers as well to our panelists. And before we wrap up, I want to also give another chance for the two of you, Drs. Cheng and Huot, to touch on anything else that you might want to share, or anything that you feel is important to highlight from this session.
So Celine, maybe I'll go first. I think a big theme out of everything that I talked about is communication. It's communicating between you and your potential partner or partners, communicating between you and your healthcare team, and talking about whatever is bothering you, planning ahead. And even if we as healthcare providers are not asking the right questions, and that will happen, and I apologize on behalf of all of my colleagues, including myself, ahead of time, because for sure that will happen. We do want to know. So share it with us. And if we don't know how to help you, then we'll find you somebody who can, or we will try to direct you to the right resources. So it is all about communication, but you absolutely, living with diabetes, should and can have a satisfying, enjoyable sex life, a successful pregnancy, and navigate through stages like menopause with as much difficulty as everyone else. So the expectation is that you should be able to experience all of those phases in the same way as everyone else, with just a few extra details that we need to think about. But that's what the team is there for, is to help you with that.
Well said. Now I will quote Gandhi now.
Oh,
Gandhi said, if you don't ask, you won't know. So if you don't ask, you won't know. It's pretty much the same. If you don't engage in the conversation with your healthcare provider, then nobody will know about the information. There's no problem in admitting that there is recreation or even abuse of the substances. It's part of health discussions. Okay, if the healthcare professional is not comfortable, at least it will be on the map and needs to be discussed further. If the person you've just confided in is not the person who actually should be taking over this situation, hopefully they will guide you to the proper person. And let's not pretend that people don't drink. Let's not pretend that people never use recreational cannabis or other substances. And if we start from there, I think it's a very good start.
Well said, indeed, to both of you. And I think that theme of communicating openly and, recognizing it can be really tough to share, but it can also open up a lot of doors to better understand yourself and to, I think, Alice, what you described as to have it be just as difficult as for someone without diabetes is a really, really interesting way to think about it. Because a lot of the time, these are challenging spaces to navigate, but to be able to handle the hurdles of diabetes well, they can feel the right amount of challenging. I want to say thanks again to you both. Again, to those who have asked comments that we weren't necessarily able to resolve or may take a bit more time, again, feel free to follow along at diabetes.ca or at Diabetes Canada on social media. And if you want specific information or direction to your situation, call 1-800-BANTING or email info@diabetes.ca. I really hope this webinar has been helpful for anyone who was curious about sex, drugs, and life with diabetes. Our next conversation will be in November, on November 3rd, for a conversation about destigmatizing diabetes. So it's a very similar notion of what the power of having an open conversation can do. So keep an eye out and tune in if you're interested. And you're also encouraged to attend our conferences if you want to take your education a step further. So we have No Limits with Type 1 Diabetes on October 15th, and Let's End Diabetes, Type 2 Diabetes, on the 22nd. Both are free events and take place virtually. So we would love to see folks there to come learn from experts, hear from diabetes champions, and gain steps from their experiences, and to connect with each other. So hope to see you there, and hope to, again, hope that this was helpful for you. I know it was helpful for me, and I really appreciate your time to our guests. So thanks again, and be well.
Thank you. Thank you, Brooks. Great job. Thank you, Celine.
Yes. Goodbye,
Take care.
everyone. Have a great day.